getting older. Something degenerates, it's like it's wearing away. Age-related, it's just getting older and older and it's wearing away. Alright? Structural defects. Structural defects can be such as what? What can be structural defects? Come on, look at the word. Structural defects. Critical thinking. I don't want you to look up anything. I just want you to stay focused on what we're looking at here. You got to push into that brain of yours now. What is a structural defect you think they can be talking about that can lead to problems with the nervous system? Look at the word structural. Structural. The spine, the spinal column. You have like lordosis, kyphosis, scoliosis. That's a structural problem. You have the head, microcephaly. The head is small. All right? Those are structural. All right, guys? Now tumors. And we know they have different types of tumors, right? We know that you have benign and malignant tumors. Blood flow disruption, such as what? What blood flow disruption that we know we talk about that you can right now say, hey, this is a blood flow disruption. A stroke, CVA, you have what? A blood clot, or you have a ruptured blood vessel.
What about tumor?
That gives you, we just passed tumors. Are you on the side? Try to get to the side, please, so you can follow. Then you have autoimmune disorders. That is a problem when the body itself attacks it. When the body attacks itself. All right. Guys, I want you to question everything as we read. Question your own head. Why? What this is about. And if you don't understand it as we go through it, then you ask the question. You guys with me?
Yes.
With everything that we are going through, and you see something that you ask yourself, why? What this is about. And it's not coming to you, ask a question and don't just move on. Okay? Alright, disorders of the nervous system. It says that disorders of the nervous system may involve the following. Vascular disorders. And when you hear the word vascular disorders, what pops into your head right away? Come on, guys. Come on. You gotta blood vessels. Vascular blood vessels. Remember when we did the cardiovascular system, we talked about the three components and everything that happens to do with reference to the cardiovascular system is based on those components. Cardio, the heart, and things that happen only to the heart. Vascular, and things that happen only to the blood vessels, whether it be a vein, an artery, or capillary. And then you have the components, which is the blood, which is the blood what? Cells, erythrocytes, thrombocytes,
Leukocytes.
and your plasma. Alright? Keep it within that because that's how you normally will do things. As I tell you guys, each area of your body can be affected, but you got to know those areas. And you have to be able to categorize it. Don't jump all over the place. Put it in the categories and stay within categories. Don't just jump over here. You read about cardiovascular, you read about blood disease, and then you go and jump over. No. Stay within each category. Finish everything, for instance, like the heart. Finish everything in the heart. Electroconduction system. The circulatory. The structural defects, like what we did yesterday in the fetal heart, with all those different holes. Stay in one area and exhaust it before going to another area. Okay? Because those areas usually impact on other systems. All right. So vascular disorders such as stroke, which we just talked about. The non-name for stroke is? Come on, non-name for stroke is?
CVA.
CVA. Right? Transient ischemic attack. A TIA. That's usually called those things like a mini stroke. You have subarachnoid hemorrhage. Remember when we were doing the brain and we said, hey, you got these different what? Layers, which we call the meninges. And we have the what? The first one is there. The first is the dura mater, right? And then the next is going to be your arachnoid. And then when you go beneath the arachnoid, that is where you find all of the blood vessels and what have you. And when they get ruptured, that's where you get called subarachnoid hemorrhage. And when you're working in the hospitals or the nursing home, you're going to see the doctors write these diagnoses, especially subarachnoid hemorrhage, as it related to patients who had a stroke. All right, guys? All right. Subdural hemorrhage and hematoma. So that one was subarachnoid, and the next one is what? Subdural. So where's the subdural going to be? Come on, guys.
Under the dura.
I use some dye this evening to dye some of these gray in my face and what have you. Don't mess it up more. Come on, you talking about dura? We just have a dura mater. Be the first layer. Why is it you can't tell me subdural mater is under that?
On the skin.
The second layer.
Subdural just is under the layer. Sub is under, right?
Yeah.
Like a submarine. You go underwater.
Right.
So the mater is the upper cover. Subdural is under that cover. We did arachnoid is the middle layer. Subarachnoid is under that. Are you guys with me?
Yeah.
Remember, two things is put you under. Hypo and sub. Keep that in your mind. Anytime you see hypo, it's under. All right? When you see sub, it's under. And the hematoma we know as no, stop. Tell me information. What's a hematoma, guys?
Swelling.
Accumulation of blood. But we talked about other blood accumulation. What were those other blood accumulations we talked about? Where you witness this blood about the body.
Edema.
Petechiae. Why? Fine blood vessels. What else?
Edema.
Well, the hickeys are petechiae. What else? Come on, guys. Come on, wake the brain up. Come on, let's go. Purpuric spots. What else? Ecchymosis. Just let it flow like that. Just to keep flowing like that. Don't throw it to one side. Bring it out. Because it's affecting the different parts of the body. All right? Now let's move. And extradural. See that dural come back? Extradural hemorrhage. Bleeding again. Up in the brain. And if you got a lot of bleeding going on in the brain, what do you think is happening? You know the struggle. What is happening? What is the rationale? What's happening?
Blood vessel.
We're gonna have
Blood
pressure.
clot?
It's a tear.
Stop! Come on, you got a lot of bleeding. What's happening?
It's a tear in the blood.
The blood ain't got nowhere to go. So it's going to increase the pressure in your head. And it's going to... No. Stop it, guys. Here, guys. You're increasing the pressure. And where the pressure is going to be placed on? Your brain. And remember you did those 12 cranial nerves? And each one of those nerves had a what? A function? Motor, sensory, or a combination? And if one of those are depressed by that increase in what? The blood,
Pressure.
be that part of the body that nerve goes to will be affected. So that part will be having a problem. That's why I tell you guys to focus on your what? 12 cranial nerves. So you did something with them with reference to the mnemonics. How to remember your 12 cranial nerves. Remember that? Now you got this bleeding and all these things that can cause you to lose the ability to control movement. Alright? Alright, guys. And now what are some infections? Infections such as meningitis. And we had talked about meningitis, remember? And we said that sometimes you have meningitis because of some kind of viral situation, right? And we talk about those kids in school where they get the meningitis. They now start to what? Check all the kids, ensure that they are not infected with anything because meningitis can lead to a terrible situation. Right? Remember when we talk about these problems with like meningitis and tetanus, all affecting the nervous system? Remember we talked about when the person lying in the bed, they hear noise, sensory, and cause them to arc the back, and they look like they have what? They're possessed by the devil. Remember we did that?
Yes.
But what did we call it? Why look at me, man? Tell me why we call it. What do we call it? What do we call that when they arc the back? Because of that stimulation. We said we got to keep the place quiet. Because the quiet helps them to stay calm. What are you meditating? You're going up in the mountains. Opus tetanus. That was the word we used, opus tetanus. And you guys remember it, right?
No.
Oh, you gotta be kidding me.
No.
We arch the back. I told you guys and we talk about it more than once. When we said that when the girl in, what's that movie that she had the spirits in her? I don't know what we call that movie again. When she got possessed by the devil and she started talking stuff and flew out of the bed and talked. This is why I remember, because I give you guys examples to make you remember things. Opus tetanus. Arcing of the back, and people are like, my God, people can do that. Grandma, you guys just forget, you know.
Yeah.
But I don't forget because y'all are surprised me the way you react to things when you see it. All right, let's move on. All right, so you have meningitis, you have encephalitis. And we use a word recently with reference to this, says encepha. Remember yesterday we did something when we talk about ceph with the CPH, what we were talking about? We were doing the maternity nursing, but we talked about something with the same ceph, CPH was is part of that word. We talk about CPD. The baby head too big to pass through the pelvic. So the baby head is called the cephalic pelvic disproportion. Cephalic refers to the head. So now you have encephalopathy when we talk about what? When the baby head, we says the baby head, right? But I think that's how we say CEPH refers to the Head, like encephalopathy, right? And we did what? Hepatic encephalopathy related to the what? The portal hypertension due to the cirrhosis of the liver. You guys remember that, right?
Yes.
Encephalopathy again, the brain. Anytime you see the word, the root word, ceph, is a brain. Be it cephalotic or encephalotic, the brain. Just remember that. So anytime you see the word come up in a question, and you see CPH, you know it's a brain the guy's work. Alright? Alright, polio. Polio, we don't really got them things anymore. I know why they mention it here. But you have condition known as poliomyelitis. Poliomyelitis. And there we go, they get this dural again. Epidural abscess. Just so we have subdural, now we have what? Epi.
Epidural.
So mean epi is what? Above. But if you don't know what is a durameter, then guess what? Subdural and epidural and all these things ain't gonna make sense to you. Are you guys with me? Please understand. As I always keep telling you, once you understand your anatomy and physiology, this will become easy for you. Very easy. Alright, now let's go to the structural disorders, such as brain or spinal cord injuries. Bell's palsy. Remember Bell's palsy?
Yes.
The one with the face, right?
Yes.
Cervical spondylosis. Cervical spondylosis. So where's the spondylosis and the cervical spondylosis? Where is it going to be? Where? Put your finger on, tell me, show me where.
Cervix. Cervical. Where's the cervix?
Let me see, where's the cervical? Don't put your hand anywhere that's going to embarrass you.
Is it cervix?
They got diff too, and they spell the same way. The one we talked about yesterday is not the one we talked about today. The one we talked about yesterday, please don't put your fingers. But you can put your fingers on the one we talked about today. So where do you put the one that we talking about today? Come on guys, put your fingers, let me see. Come. What? Everybody, put your right hand up. Everybody, put your right hand up. Take your right index finger and put it on your cervical spondylosis area. Put it. Lord have mercy. Lord, you got 7 40 blood. 7 again. Lord have mercy. Ay. All right, let's move on. Carpal tunnel syndrome. Well, everybody know that. Because everybody's on the phone. And the kids getting problems with their hands and their wrists and what's that? Carpal? Remember? Carpal? Got the carpal. Alright? Next.
Brain and spinal cord.
Brain or spinal cord tumors. And we don't have to go because we know what the tumors is. But one of the things you got to remember about tumors is what? One of the things you want to remember about tumors. Apart from it being what? Malignant or benign. What else you do think you have to remember? Tumor spread, right?
Yeah. That's my. Yeah.
So we call what's that?
Metastasis.
What she said?
She said metastasis. Metastasize.
You said that?
If I see that,
Let's metastasize. Okay, we understand it spreads. But something else I want you guys to what can be a defining factor when you're thinking about things that are benign That is tumors I'm talking about, sorry, not things, tumors, benign or malignant, which is cancerous, right? All right, so you look for things that tumors are encapsulated. So right now, just to make you get into this, look for tumors, capsulated and encapsulated, please, quickly so we can move on. Tumors, capsulated and encapsulated. Anybody read, please?
A tumor capsule is a layer of tissue that separates a tumor from the surrounding normal tissue. A capsule may be present around both benign, non-cancerous, and malignant, cancerous tumors. However, not all tumors will separate from surrounding normal tissue by a capsule. Tumors that do not have capsule are sometimes described as non-encapsulated.
So what does that tell you? What that tells you? Come on, think of it. What does being in a capsule tells you?
It's not going to spread as much.
It's not gonna spread.
It's separated from the healthy tissues. It has something like a barrier between the tumor, whether it is malignant or not,
Yeah.
but it's separated from the healthy
Surrounding normal
tissues.
tissue.
Guys, stay with that, please. Just remember that. You have things that are capsulated and encapsulated. And most of these tumors that are benign are usually
Capsulated.
All right, the benign tumors. And then now we go to what? Peripheral neuropathy. Which condition we talk about that you find you come with peripheral neuropathy? Diabetes, endocrine system. So you
No.
we did it recently. Diabetic, right? When you getting those sticking in the legs and pain in the legs and what have you? Peripheral neuropathy. Peripheral. It's affecting what? Your PNS. Your peripheral nervous system is being affected by an endocrine problem, which is diabetes. And how many types of, what different type of diabetes do we have?
1 and 2.
Two times.
So you talk about two types, so what are they?
Diabetes type 2 and juvenile.
Type 1 is
Juvenile.
is known as a juvenile diabetes. Good, very good. Type 2? Usually said as a late onset diabetes.
Insulin
And
resistance.
what is the difference between the two? Between the juvenile and the late onset?
The juvenile, you get it at a young age.
You don't produce enough insulin.
You don't produce a lot of insulin, so therefore these persons usually be on
On insulin.
insulin.
Yeah.
While the late onset, they usually start off with what?
Medication.
Medication.
Diet.
Yeah.
You want to look at the diet first. They want to tell you, stop eating a lot of
Sugar
food stuff,
stuff,
right?
yeah.
And then when you find that person don't really listen, so they go to the next step. They give them what?
Insulin.
No!
You give them the
You give them
metformin,
tablets
yeah.
to help the insulin to be produced. Things like metformin. And then when that too becomes a problem, because people still not adhering, they now have to go to what? Insulin. And they usually, this is the person that they usually put on a what?
Sliding scale.
A sliding scale. Based on doing their finger stick, and if the finger stick has X amount, you're going to say you give X amount of insulin. Okay? All right, guys, you see how when you're talking about CNS, how other things we can talk about at the same time? Try to do this all the time. Try to make the connections all the time, because the body is connected. The body is one thing. Like when you do your holistic nursing, everything is connected. All right, and then you have what? Guillain-Barré syndrome. And what do you remember about the Guillain-Barré syndrome? Come on, we did this. What did you remember the Guillain-Barré syndrome? If you stop your head, still remember. You want me to stop it for you?
No.
Oh, let me punch you there. What did we talk about with the Guillain-Barré syndrome?
Damages the nerves.
We said that with the Guillain-Barré syndrome, the person can recover. But one of the things that makes you know the person having Guillain-Barré syndrome is when you're having what? Ascending weakness. It travels from the leg going up. It don't start from up and go down. And that's a defining how you can easily say, oh yes, this person have a Guillain-Barré. And Guillain-Barré do not affect your central nervous system. It affects your peripheral nervous system. Because we know most cases where you have a problem in your CNS, it is progressive. And it usually get what? Worse. Come on guys, stay with me. The CNS is usually progressive. Like your Parkinson's, your MS, your Lou Gehrig's. It starts to get worse, right? And someday they're going to kick the bucket because of it. But the PNS, you can treat, and the person with Guillain-Barré syndrome can be okay. They can get well. But when we have done the CNS and we specifically look at certain diseases, like we just have with the Parkinson's, right? And let's continue the overview. Let's see if those things are going to kick out back and you guys can remember. All right, and then we go to functional disorders. So if you notice, just like what we tell you, everything is being put into what? Categories. You have the vascular, you have the infection, you have the structural. Now you go to functional disorders such as a headache, epilepsy. And when you talk about epilepsy, what type of epilepsy did we talk about?
Seizure, recurrent seizures.
Yeah, seizures, but what type of seizures? Epilepsy is just another name for seizure.
Recurrence.
The what? Grand mal seizures, right? Petit mal seizures. Yesterday we talked about one. What one did we talk about yesterday? Eclampsia. Seizures that is associated with eclampsia. The petit mal, you don't really see anything. But the grand mal is just where you go through those 4 stages, right? The aura, the tonic, the clonic, and the post-ictal phases. And when you talk about seizures, it means that the body, the electrical, because you know everything in the body is electricity, right? Gone. It's like when you put too much of one point, you put too many what? On an outlet. Too many points in it, right? And next thing you can have, Now when you're outage, you could get a fuse blow, the whole house get it black until you do something, right? The body's just the same way. Now degeneration, that's the word I asked you guys about a short while ago, right? Such as Parkinson's disease, multiple sclerosis, amyotrophic lateral sclerosis or ALS, also known as the Lou Gehrig's disease, Huntington's chorea and Alzheimer's disease. When something is degenerative, it's going down. We just talked about it, progressive. It will only get what? Worse.
Chronic.
So you're not gonna be expecting this person to get what?
Better.
Better, but you're working with this person so they can enjoy what they have.
What is
Huntington's is chorea. It's very, in fact, I've only seen one case in my nursing career. It's a woman, and she completely lost all control of bodily function. Total care. And she was pretty young. She was in the latter 30s, early 40s. And what was so fantastic, why I remember her, is not only that she's the only Huntington chorea I've ever seen, but I remember her son, and he's the first guy that I've ever seen with these big tattoos who tried to get it off. So he was having these different surgical procedures to get rid of the tattoos. But what was so good about him, and by the way they're white, which is most of the people who are affected by this, he will come and change his mother, clean his mother. Everything he do for her. I know a lot of us said, well, you know, you don't want to be cleaning your mother's private parts and that sort of stuff, right? But he did everything.
We had one that was listening to a guy come and clean his mother every day. He don't want you to touch her.
And you know when my mother was, she got the stroke that finally killed her, my brother, my older brother, he used to go and clean her every single day. Every single day. You go clean her, change her down, do whatever you have to do until she passed away. He's a different person. Quite different because I don't know if I could do that. I think I'm more likely I would not be able to do it. All right? That's for sure. So now we go to the signs and symptoms of the nervous system disorders. All right? They say the following are the most common general signs and symptoms of a nervous system disorder. However, each individual may experience symptoms differently, and these symptoms may include persistent or sudden onset of a headache. Why is it that, stop, let me stop a moment. Why is it Mr., what's his name, Mr. Lawrence? Let me say it again. I had to put 2 students out of my class, right? I'm telling you guys again, if you guys, look, I don't want to be getting upset. Do not come into my class dressed inappropriately. You guys only have 4 more weeks. Please do not dress inappropriately in my class. In fact, in the Saturday class, I asked Stanley not to send a young lady back into my class. And I'm not kidding around. Don't come into my class dressed that way. And this is the last thing I'm going to say. Yeah. All right, signs and symptoms of nervous system disorders are the most common general signs and symptoms of a nervous system disorder. However, each individual may experience symptoms, different symptoms may include. So now let's go to those difference in the symptoms. You may have a persistent or sudden onset of a headache. You know, a lot of people also get headaches.
Migraine.
And you got to be very careful with headaches. People who keep getting headaches all the time need to do what? Find what is the underlying cause of the headache. Don't assume, because most of us assume that the headache is due to stress. We said it's due to something to eat. The headache may be due to their eyes. Could be a lot of different things can give a headache. But if a headache is persistent, that is something that you need to check out. A persistent headache is a warning, guys. Pain is a warning. Regardless of wherever you get the pain, it is a warning. If you get pain in your eyes, it is a warning. You get a pain in your mouth, it is a warning. You get a toothache, it is a warning. So you get headaches, it is a warning. Okay? And it said that a headache that changes or is
Different.
different. Loss of feeling
Or
or
tingling.
tingling. That's what we just talked about peripheral neuropathy, right? So you get some tingling in the what? Where are you going to get this tingling? Especially the lower extremity. Remember, peripheral goes to your extremities. Be it your legs or your hands. Extremities, right? Now, if you have loss of feeling, what does that tell you? Nerves. Remember, there we go back to what? Afferent and efferent. Sensory and motor.
Motor.
So sensory is going to your brain. So that is what? Afferent. The brain sending back messages. Motor. Efferent. So if your sensory is not working well, you're not going to what? Feel. You're not going to feel. And again, we're going back to the what? Those 12 cranial nerves. Now, weakness or loss of muscle strength. When we talk about weakness, what's a medical term used for weakness? Come on, guys. Come on. What's a medical term used for weakness?
Paralysis.
What's the medical term for weakness?
Paralysis.
We shouldn't be here. Come on. We use two terms when we talk about patients who have CVA. Bring it back now. I'll give you the answer there. What does a patient get when they have a CVA? Hemiparesis, hemiplegia. So the paresis is weakness. Plegia is when the person is what? Paralyzed. Guys, you know what you're going to do for me now? Look up hemiparesis. Look up paresis.
Paresis. How do you spell that?
Somebody read. In fact, you shouldn't even read that. That's paresis. You ever had paresis? Remember when we went through it? We said that the person having paresis, they could still what? Move, but they're going to move slow, right? But when the person have a hemiplegia, they can't what? Move. They can't move that part because it's lost all what? Because there's no nervous control there any longer. Now the next is loss of sight or double vision. What is double vision? Medical terminology.
Diplopia.
Oh, thank God. Tell them again, man. Tell them again.
Diplopia.
Diplopia, all right. So we have double vision. Or even loss of vision. Remember we did the 5 things yourself? That's affected?
Diplopia.
Okay, So you have the loss of sight. Then you have memory loss. A lot of people lose their memory, right? And when we're doing our BIMS, which is a brief interview for mental status, and we had that score of 0 to 15, right? Memory loss. We talk usually of two types. And the two types are
Let me remember.
Dementia?
short-term and
And
long-term
long-term.
memory loss.
Memory loss.
Then you're now going to associate it with whatever disease process. Dementia, short-term memory loss. And then as it gets severe, you lose everything. Now, what do you think they mean by impaired mental ability? What is impaired mental ability? In your term, or what you understand impaired mental ability to be?
Loss of mental function, such as thought patterns, ability to
Basically,
reason.
person losing the ability to make decisions.
Yeah.
Basically losing that, because you guys do critical thinking to come up with a valid decision, those persons lose the ability to do that. All right? Then a lack of coordination. What condition we talk about that really show you lack of coordination? Which condition we talk about? Parkinson's. We talk about Parkinson's, we talk about what? All of these have lost the ability to coordinate movements. And some of them have problems with their memory and decision making too. Except which one you said that the person loses all ability, coordination, and even one day will stop breathing because the muscles are just deteriorating. Which one of those diseases we said that was affected with?
Multiple
And the person
sclerosis.
still have the ability to do what we're talking about. Critical thinking. The person don't lose anything in their mind, but the body's just deteriorating.
Multiple sclerosis.
ALS, the Lou Gehrig's disease. Guys, I want you to remember that because he was a famous baseball player. And his mind is still there, but the body is going. And the thing about it, they will even stop breathing, but the mind is still very alert. Okay? Muscle rigidity. You can see part of it when you look at, and you can break it down even when you look at a person who having a seizure. The tonic phase of a seizure. Muscles are rigid, right? You have other conditions. And result in the patient being very rigid. Very difficult to work with these patients, especially the primary caregivers, because in cleaning these patients, the arms decorticated and have you the arms and the legs. It's not just where you're having contractions, but we just talk about generalized muscle rigidity. Not just contractions. Then you have tremors and seizures, and we kind of talk basically about that. Back pain which radiates to the feet, toes, or other parts of the body. Why do you think it radiates? Why do you think the back pain radiates to those parts of the body? Because of the nerves. Where it starts, that's the origin. So a lot of people might have had an injury, trauma to the back. And because from that area going down is where you have all the nerves are going, that pain will radiate along there. If you now had the damage to that spinal nerve, and when you mean damage, it's cut off, nothing can go down. So no what? No signals are going. So now no pain is going because it can't have no what? Remember we just said what? Sensory and motor. So no sensory can go back because it's what? Cut off. Nothing is going up to the brain. It's cut off at that point. So the brain don't know. So the person will have what? No feelings, no sensations. Okay? Guys, make a connection between those CNS and your PNS. Always make the connection between your CNS and your PNS. Alright? Muscle wasting and slurred speech. Why the hell do you think you get a muscle wasting?
Because they're not using to exercise. It's difficult.
Why do you think you're getting muscle wasting?
That's the message comes from, the message initiates
Coming
from
from
the
the
nerve
brain.
to the
rest of the body.
to the muscles. I mean, to the muscle. If that message is not being sent to the muscle is not working. So it's gonna
You know
waste
there's
off.
one saying you can put it in a capsule. If you don't use it, you're going to lose it. And the message is not going to the muscles, so the muscles are not being what? All the function of muscles is to contract and bring bone towards bone. So now no message is to go down there for it to what? To contract. So it's going to what? Lose it. And then it's going to just wither away and get small. You ever see those guys who in the wheelchair and do those Paralympics and what have you? Up here is big, powerful. Down here, tiny little thing.
Tiny little thing.
Slurred speech. It depends upon the area that is what? Of the brain that's affected, that's going to cause you to have slurred speech. When you're having slurred speech, it's affecting what? What is slurred speech affecting? Come on. What's slurred speech going to affect? When you write in your care plan?
The tongue.
Communication. You know the senses we're talking about? So you're having communication. So if you're having slurred speech affecting communication, what are the medical diagnoses that are related to these communication?
Ineffective communication due to.
What are the medical diagnoses? What are the medical diagnoses? Listen to me what I said. What are the medical diagnoses related to this communication and the ineffective for your nursing care plan? It's going to be ineffective communication. Change in communication pattern. What it is. What is the medical diagnosis that supports it? You give the nursing diagnosis, so what is the medical diagnosis going to support it?
Dysplasia, aphasia.
Say it again.
Dysplasia. Or
Not
it's gonna be
dysphagia.
aphasia.
It's going to be aphasic. Aphasia. Oh yeah, wow. Wow, got it.
That's right there,
And you have three types of aphasia I told you guys about. One is when you can't express yourself. So that is called what?
Expressive
Expressive aphasia. And the one that you can't understand when people talk to you. It's called receptive aphasia. And when you don't understand and you can't talk, it is called
Cognitive?
global aphasia. Everything global.
Okay.
Okay. Now the central nervous system disorder may look like other medical conditions or problems. Again, the symptoms of a nervous system disorder may look like other medical conditions or problems. So sometimes it can cause doctors to mix it up. Right? Always see your healthcare provider for a diagnosis. And what do we call the term when you're looking at two diagnoses that are similar and they have to come to the right one?
Dual diagnosis.
What?
Dual diagnosis?
No.
No?
Two very similar, but they have to come to the right one. And we went through this for 15 to 20 times. It's called differential diagnosis. Now, let's move on. Now, healthcare providers who treat nervous system disorders. And so the best way to manage nervous system disorders is with the help of a team of healthcare providers. I may not need all members of the team or any given time, but it's good to know who they are and how they can help. Now here are some of the lists of the healthcare providers related to the CNS system. You have the neurologist. And the neurologist is a medical healthcare provider who diagnoses and treats nervous system disorders. And some neurologists treat acute strokes, which you know is a CVA, and cerebral aneurysm. Somebody just said, you said aneurysm just now when we were talking. What is an aneurysm? No. Aneurysm, no burst, no blood vessel.
It's a bulge.
It's a bulge, not a burst. Don't mix it up. It's bulging due to the weakness in the walls of the blood vessel. And this one's cerebral, meaning it's in their brain.
Right.
And then you have the neurosurgeon. And those are persons who operate as a treatment for nervous system disorders and are called neurological surgeries. And these persons are neurological surgeons or neurosurgeons. And then you have the neuroradiologists and interventional radiologists. This is a radiologist who specializes in diagnosing nervous system conditions using imagery and in treating nervous system conditions such as cerebral aneurysm, acute stroke, and vertebral fractures. Now this provider also does biopsies of certain tumors. Now the psychologist. Now we're going from something that is material to something that's non-material. So the psychologist deals with emotional problems such as anxiety,
depression, mood
swings,
and irritability.
And what condition you think will give you mood swings? What condition? Let's just pick on somebody. That guy who punched somebody the other day, that boxer.
Mike Tyson.
What do you say that?
Bipolar
disorder. Sometimes he's high, sometimes he is low. Alright? And irritability are common in nervous system disorders. And by the way, when we're doing the psychiatric part, because CNS is related to the psychiatry, we kind of look at it with the psychiatry in two areas. One will be neurosis versus psychosis. Okay? Now, psychologists may also do testing to find out how much your disorder is affecting the way you think and feel. That's gonna cost him, right?
So get your bag. Oh, that's yours? Yeah. That's it?
Alright, so psychologists may do testing to find out how much your disorder is affecting the way you think and feel. And the psychologists also do talk therapy, which is called counseling, to help you deal with emotional effects caused by nervous system disorders. So many times you see psychologists on the jobs, right? And they usually come and talk with the patient. And here, doctor, somebody's here to talk to the patient. It's a psychologist. And you're going to see the difference between a psychologist and a psychiatrist. Don't mix it up. A lot of times you see a psychologist come on the floor, and we hear the psychologist is there, and people seem to think that he also has something, with a psychiatrist. So we're going to see the difference now. A psychiatrist, like a psychologist, this team member deals with emotional and behavioral symptoms caused by nervous system disorders. In most cases, talk therapy works best for these problems, but if you need medicine to treat symptoms such as depression or anxiety, the psychiatrist is the person to do it. So, what that tells you now, between the two, the psychologist and the psychiatrist. Both of them can counsel, but only one can give
prescription.
And what medications would he be given?
Psychotropic medication.
Psychotropics. And when you talk about psychotropics, what are we talking about? What type of medications? Antipsychotic, anti-anxiety, anti-depression. All of those come under psychotropics. Okay? Now, remember when we did the physiatrist? When I asked you what's about physiatrist, and some of you had some concerns. The physiatrist, the healthcare provider who works with people in the rehab. The physiatrist works in the rehab department. The physiatrist is the physiatrist is the rehab specialist. Okay, so I do attach these here. All right, no problem. All right. Now, the physical therapist. And we know who's a physical therapist, so not even going to go into that. And the occupational therapist, we know who's an occupational therapist, right? Yes. We ain't going to go into that. Speech therapist? Speech therapist. We're not going to all of that, speech and language. But why do you think they mentioned those three people? The physiatrist? Because on some what they're talking about with the psychologist and the psychiatrist. Because remember, these persons can have problems such as what? Dementia, right? Because of the problem they have in their head. What was the problem we said yesterday when we talked about people who have babies? What's the psych problem?
Postpartum blues, postpartum psychosis.
And they have, what the word was it? Psychosis. And how do you define psychosis being?
Self-harm.
Something else. Define what psychosis is. Come on. Psychosis. And this we're going to stay with you all the time. what is it psychosis is about, as different from a neurosis?
Delusions.
Psychosis deal with the brain? No. They don't.
Both are dealing with the brain. One.
They're delusional.
One is has loss of touch with reality. They are in their own world. They're going to see things which we call what? Visual hallucination. They're going to hear things.
Auditory hallucination.
Auditory hallucination. Hallucination. And these persons have a tendency to be what? When they are in their own world and believing it, we say that they are the D word.
Delusional.
Delusional. What people tell you you're deluded, meaning that you're in touch with reality, you're talking crap. So persons are delusional. Hallucination.
So what? So what's the job? What's the function wide of psychiatrists?
For psychiatrists, again there, you can think about person getting problem. Because remember, the CNS is not just about message being sent back and forth to the brain, but it also covers what? Thinking, emotion, okay, mental. So that's how your psychiatrist and your psychologist come into play. Now for the rehab people, what happened, and think about the things you just talked about. Person having what? Stiffness, no coordination, muscular coordination. You working now at wherever you're working in a healthcare institution, you find that the person had a stroke. Who do they go to? Where do they go? Therapy. Rehab therapy.
Physical
Occupational,
therapy.
physical therapy. But they had a stroke.
Loss of function.
ADL problems. So they're going to be what? Having to be brought
Rehabilitated.
back to the former level of
Function.
Prior level of functioning.
Or
So that's
optimal.
why they need to have the psychiatrist, who's like the specialist over all those,
Areas.
physical therapy, occupational therapy, and the person who he had a stroke, but not only that he have this weakness, they're going to work on that, right? To get it what? They call it endurance and strengthening training, right? But he might have problems because remember, hemiplegia is one side of the body, right? And sometimes that part of the brain that is affected, because what's affecting the left side brain, the right side is your body, the right side of your brain, the left side of your body, right? Crisscross. Person may have problems with speech. We just talked about it, slurred speech, right? But the person may also have problems with eating. And that's where you need to have who? Speech pathologist. And what she's checking for. Not only for speech production, she's also checking for swallowing reflex, your gag reflex. To see what is the consistency. Should this person have clear liquids or thick liquids? Can they have what consistency of food? And then they make the recommendation to who? To the primary doctor. Then the doctor is going to order what type of diet the patient should be on. So that is the connection. You got it there, Rika? Pretty much understand, right? So those are the people. Now what you need to get to, which we looked at, just remember that persons who have problems affecting the CNS, and we know about Parkinson's, right? You know about the difficulty. This is one of the questions that will come up in your the state boards, your NCLEX. Why does Parkinson people have they have that problem in making the first step? That's why they be like, I used to just shaking their move, attempt to move. Their problem is initiating That first
Movement.
step. That's why they be like, and then they. But to make the first movement is difficult for them. So your teaching is about don't try to go forward, go back to first and then move. Go back first and then move forward. Because here they're going to stop and they'll be like, and then they're going to be,
Are they afraid to move because?
and then they fall. Because now your main thing with these people with central nervous system problem like Parkinson's and MS and your Lou Gehrig's and all, safety. And because you know it's progressive, what you're going to want to focus on. Because these diseases are progressive.
Slow it down.
Comfort.
Your ADLs, activities of daily living. They can't do the things that they normally would do. And you being registered nurses, you have to look at 4 ADLs. Because those are the 4 that they're paid for. And they're called late loss ADLs. And that's where the money comes in. And the late loss ADLs is eating. Transferring. Bed mobility. Toileting. Those are the 4 that facilities are paid for. That's where the big bucks come in. And they call them late loss because those are the things that leave you last. Although you may have problems going on, you damage your spine, you're still eating, right? Eat you? Eat. Still going on. Person has severe dementia. If you have dementia, they're eating, they don't know what to eat, but they're eating. But reach a point where they're no longer going to be what? Chewing. So that's where maybe they have to get their GT chew. The central nervous system controls both the voluntary and the involuntary. Just keep that in your head always. Emotions. A person who loses control, all your CNS. A person pick up a gun and want to go and shoot up everybody. Central nervous system. A man come home and box his wife because she didn't cook. Central nervous system. A woman said nothing for you tonight. Central nervous system. Makes that decision. Okay? So our central nervous system is not just related to the physical. That's why we have the psychiatrists and the psychologists. And a lot of people get carried away and just focus only on the physical attributes that's affected by impairment of the central nervous system. You know, so let me give you an example. In New York, we have something called no-fault insurance. Some of you might have heard about it, right? You get in a car accident, you have a no-fault insurance, and what's the first thing you get? It's whiplash, right? You put on something in your neck, and then you're having problems, oh, you know, my neck can take in a couple of months, and you keep thinking you're going back. They're going to send you to the neurosurgeon. And neurosurgeon may say, oh, you know, the bones in here are a real problem. So what are you going to say? We could do 1-day minor surgery, and it will be fixed. And you will say what? Do I have to do it, doctor? And he said, no, I'm telling you, but I think it's best to do it. And you will say, I really want nothing to touch up my spine and cause me to. I said, no, it's a minor thing.
hear the money.
Why? Because when he do the surgery,
Get more money.
whole lot of money. And if it's me, he asks, I will say yes. Because once he put his hands on me to do that surgery, it's $50,000.
What?
It is $50,000. And if you have a good lawyer that shows that what happened, he can get lots more. But the basic is $50,000. That's the basic. If you get your little finger crack because when you're driving, your car slam into another one, your finger hit something and you get broken, $50,000. But then the law is going to take 1/3. So you're going to have to pay 30 something, 36,000 something. And you know what about it? It's
No
tax free. So think about this the next time you get into an accident. Think about it. Because no. You gotta know these things. You gotta know these things. And it's good to share these things. If you're sitting in a car and you are not the driver, and the car gets into accident, and the driver is your husband, sue your husband. Absolutely. Because insurance, you're sitting in the car, you're a passenger, you will get paid. And the thing about, and he's going to benefit from it too. And especially somebody hit the car, you're going to sue the driver of the other car, and you're going to sue your husband, the driver of the car.
And if it's a rental,
I'm telling you, that's what it is.
people too.
And you will get the tools because the person who hit you, hit your husband's car, that person have to pay for both. Because your insurance company is going to go after his insurance company. So that not coming out, and that's why they call it no fault. It is not your fault. It is not your fault. That's why they call it no fault. But anyway, why I told you this is because when you have these things, these neurosurgeons love to do these little minor, just to go in there and just do a little something that take you like 5 minutes, and you get maybe $20,000 to $30,000 to do it, right? And your lawyer will push you to do it because he's going to get $150,000 or more, right? So everybody gets something out of it. But the problem is, as you know, most of you end up going to these rehab places where we're talking about, and you go there for what? 2 years, and then you end up getting $5,000. That don't make sense. All right. So you have the physical and the mental aspect of the central nervous system. The one that you guys kind of, stay with me guys, the one that you kind of focus on, especially in long-term care, is the dementia. We mentioned dementia recently. Guys, you remember what we talked about? We referenced the dementia that you mentioned recently. This dementia is related to blood. I didn't have lunch today, you know. And I'm talking about wrong, right on my blood sugar.
Hypertension, dementia,
And you guys
something
sitting
about
and I'm talking and moving, so you doesn't want me to collapse. Guys,
hypertensive.
if I said that the dementia I'm talking about was related to your blood, what would take me so long to jump on it?
Hypertensive dementia.
We talk about vascular dementia. We went through vascular dementia. We say, oh, you got a high blood pressure. Lord have mercy. You don't know when I'm having conversations, I'm trying to meet somebody online to, get a date or something. You say, why are you talking so strong? Why are you so... I can't tell you, these students I talk about because this is the way they make me talk. They bring back my military with me. Lord have mercy. All right. Look up vascular dementia, please. Look it up now, please.
I'm coming, okay? Give me a second. Vascular, you want me to read, sir?
Yes.
Vascular dementia is caused by an irreversible alteration in brain function that damages or destroys brain tissue.
That's all?
There's more. Want to continue? Brain injury from ischemic or hemorrhagic damage. Vascular dementia is the second most common cause of cognitive impairment in the elderly. The incidence is closely associated with hypertension, but also with arrhythmia, stroke, peripheral vascular disease, lipid abnormalities, and diabetes mellitus. The usual onset is between the ages of 55 and 70 years, and more men are affected than women. Continue.
No.
Oh,
Guys understand what vascular dementia is now? What causes the vascular dementia?
hypertension.
Alright? Damages the blood. Now think of it. Think of all the damages that's happening around the body, the blood vessels. When we have problems with the blood vessels in the heart, we have CADs, right? Coronary artery diseases. When we have in the brain, cerebrovascular artery or accidents or diseases. Damage of the blood vessels, whether by either the endocrine system or any other traumatic situation, can lead to different disease processes. Earlier we talk about diabetes causing the damage it causes your peripheral neuropathy. So that's structural changes. We had all of these things. But what do you think is my biggest concern today?
The laptop and the iPad from Venice.
We're going over things that we did.
Yeah.
I want you guys to respond a little faster. As I'm going over it, because I got these little notes here yesterday that says that people were having some problems with it. So we now know to differentiate. Put each in its own
Your battery is
category.
dead.
Alright?
Your battery is dead. Your battery is dead. That's why.
All right. Okay, 1 minute, and then we go on to the next section.
We can go now. Guess not. Oh, for the sake of time, we can go now. Stop whispering. What did you say?
Notification and I gotta update it.
You gotta update your computer? Bring it. I'll take a look at it. Are you gonna wait after class? You can wait after class. It's up to you.
You see it saying?
Cause when you update it, oh yeah, you gotta click on this thing, right? When you click on it, it wants to take you to the
different
app
steps.
store, right? And then from there you see another prompt, how to
do it.
yeah.
Okay. All right, thank you.
If you have any issue, just let me know over the phone or something, all right?
Appreciate it.
I'm hungry.
Now the question is, what is a mental disorder? So let's see what is a mental disorder. And somebody read, please.
A mental disorder, also called a mental illness or psychiatric disorder, is a behavior or mental pattern that causes significant distress or impairment of personal functioning. Continue reading.
Continue.
Such features may be persistent, relapsing, and remitting, or occur as single episodes. Many disorders have been described with signs and symptoms that vary widely between specific disorders. Such disorders may be diagnosed by a mental health professional, usually a clinical psychologist or psychiatrist.
All right. We kind of went through this when we talk about the psychologist is the one who have the discussions and what have you, and the psychiatrist is the one who now won't have discussions, but they will order medications to treat the behaviors that is related to the disease. But the person who makes those diagnoses, those mental health diagnoses, is usually the psychiatrist. All right? And the psychologist too will refer patients to the psychiatrist when you think that the behavior can be a problem. Now what I want you guys to know now is that because the use of psychotropics has an effect on a patient's mental status and their ability to do what you normally do, critical thinking. The use of the drug is monitored because it now comes under the category of a chemical restraint. Before persons were put on these psychotropic medications because of behaviors. But did these behaviors require psychotropic medications? No. A person walking back and forth, which can be pacing or wandering. Could be either one, depends. A pacing is when the patient walks
Back and forth.
back and forth,
All
but they
right.
know where their room is located. And they could walk and go back to their room. But because of what is happening to them internally, they have to walk back and forth to deal with that anxiety that's happening to them. Whilst a person who wanders, move around, oblivious of their own personal safety. These are the patients that do usually get punched out by other patients because they wander into other patients' rooms. Some persons will push them over or hit them or what have you. So what staff do, especially in time of shortage, they will say this patient always going to another patient is causing problems. The psychiatrist is not there on the floor. The doctor is not there on the floor. So who do they depend on? The staff. So if the staff is saying this patient is just a couple, moving up all around, touching things and what have you, what do you think the psychiatrist is going to do? Based on what you have said, and then, you documenting, he's now going to take this documentation, put it in his notes, and he is going to order medications. Medications that the poor patient don't need. So that patient before who was active is now walking around like a zombie. And I always tell people, think about if that patient was a family member of yours.
That's right.
Think about it. If that patient was a family member of yours, and you know this family member, you know how they behave, and then when you go there, they're like, mouth open, thing dripping, and all that kind of stuff. How would you feel? Especially that person being very close to you. Do not document based on convenience. Based on you working at night and you want no patient get up and walk around your place. You want some sleep too. So you're going to get patient getting medications to sleep. So the poor patient be put on medications. Now, just put down these couple of under pharmacology, because this is what we're talking about. Put down psychotropics. And under psychotropics, I want you to put hypnotics. Or psychotropics, like psychoactive medications. You put hypnotics. After you finish with hypnotics, put down anti-anxiety. The broad heading will be psychotropics or psychoactive medications. The first one I asked you to put down is what?
Hypnotics.
Hypnotics. Hypnotics. Hypnotics. The next I want you to put down, guys, turn me please, anti-anxiety. The next will be antidepressant. The next will be antipsychotic. Please do remember that these are all chemical restraints. You have physical restraints, you have chemical restraints. And if a patient is on chemical restraint, the facility must have an independent pharmacological consultant to come in every 30 days to look and see why this patient is still on it.
Can you sing it to me?
Mr. West, you said if the client is on psychotropic medications, the doctor must come in every 30 days.
Consultant pharmacist. The psychiatrists have to also review medications every 30 days.
Consultant pharmacist.
And the psychiatrists have to review the medication every 30 days. Guys are there. On to the review of the medication. Use of psychotropic medications, especially the antipsychotic medications, can lead to a condition known as tardive dyskinesia.
Can you say that one more time, please?
Tardive or TD, tardive dyskinesia.
You say use of psychotropic medication or
Antipsychotic medications, especially antipsychotic medications, can lead to a condition known as tardive dyskinesia. Just look up what is tardive dyskinesia, please.
tardive dyskinesia.
Read, please.
Tardive dyskinesia is a disorder that results in involuntary repetitive body movements, which may include grimacing, sticking out the tongue, or smacking the lips.
One more time, guys, so listen, please.
Okay. Tardive dyskinesia is a disorder that results in involuntary repetitive body movements, which may include grimacing, sticking out the tongue, or smacking the lips. Additionally, there may be rapid jerking movements or slow breathing movements. What does that mean? Breathing. W-R-I-T-H-I-N-G.
W what?
W-R-I.
I-T-H-I, writing movements. It's
Yeah.
like a person movement. It's a movement disorder. Writing.
Squirmy. Okay.
So the use of these medications not only gives the patient problems with chemical restraints, but it can also cause this tardive dyskinesia, including problems with movement. So the movement can be affected not only by CNS problems, but the medication itself can cause it, especially these antipsychotic medications. And remember, under each one of those categories that I just give to you, please look up the necessary medication. What is an anti-anxiety medication that is being used? What is, in fact, do that right now. Each one of you pull up one anti-anxiety, one antipsychotic, one antidepressant, one hypnotic, and see what you can tell me about it. Randomly ask someone to tell me.
It's gonna fall.
Hypnotic. What's a hypnotic? Anybody?
Sleeping pills. To induce sleep.
The one that is used a lot in facilities, Ambien.
Sleep.
Sleep.
Mm-hmm.
And usually put a list of common. Don't want to put list medications we're using in Africa or India or China. Want to use the ones they're using right here in America.
Sedatives.
Now look up, next was what? Anti-anxiety. What's anti-anxiety medication?
That's
What is an anti-anxiety medication? We know it's good for anxiety, right? Benzodiazepine. That's the only one?
Klonopin, Adderall.
Klonopin, that's what I want to hear. Why I want to hear Klonopin?
It's the one used mainly in the nursing home.
Yeah, but there's another thing to Klonopin. What's Klonopin come under? Kind of doctor just,
Narcotic.
there you go.
Xanax
Narcotic.
also. But they're all narcotic.
Xanax.
Xanax,
They're all narcotic.
all narcotics.
And
Alright, so those, definitely, you have to keep an eye on that. You don't want to disappear it. Which when medications are being taken by the medical staff for their own personal use, it is called,
Medication manipulation.
what do you call that?
A crime.
what is that?
When medications are taken
It's
by
a
the
crime,
staff
right?
for their own personal
You'll go to
use.
jail for it.
And the term
You
that
will,
you
right?
use when you're documenting,
They give you like rehab.
Oh shit, okay.
the term
You
that
come back
you
to it.
use is drug diversion.
Okay.
And that is used for your documentation, guys. Due to drug diversion, legal action was taken. Okay? You gotta use these terms. I gotta fail with it so that you, when you're talking or you're writing, you'll be on point. Next one is antidepressive medication.
Laxel, Lovenox.
said antidepressant, right?
Antidepressant.
Lexapro.
Lexapro.
Paxil.
Prozac.
Prozac. Lovenox.
And guys, I want you to be familiar with these drugs. Because these are common drugs and you know, they're not gonna ask you what is an antidepressant or whatever. They're gonna just put the patient is on how much milligrams of this medication and basically you should know what it's all about, okay? The next category was antipsychotics. What's that?
Risperidone.
Quetiapine.
It's common.
Quetiapine.
That's Seroquel.
Seroquel. That's the one.
And
we're looking
Risperidone.
for. Risperidone.
Risperidone.
Those are the
And then you said,
very, very common.
I give it a lot.
You know Haldo? That's a big guy. Hit you with Haldo, that's it.
Aldol.
Or you see Depakote can also be used for seizures. And by the way, persons who are on anti-anxiety medications, they also use it for patients who don't want to eat. Help to snap them out of it. So the primary care physician just can't go ordering medications for patients. And every month you have to review the medications and ensure that it is not becoming a chemical restraint. Patient, you got when you put a patient on restraints, regardless if it's chemical or physical, the thing is, what are you doing to get the patient off?
Titration.
That's the very first thing. What titration?
Such as
There's a term. You're the right track.
weaning them off medication.
GDR. Every patient have to have GDR done. And what is GDR? Gradual dose reduction. Please look it up right now.
Gradual dose reduction definition. Bless you.
Gesundheit. And all the what you call it? Jewish Bible. You guys see what's gradual dose reduction?
Mm-hmm.
Every doctor have to do it once the patient is on these antipsychotics medications, the psychoactive medications. So don't forget GBR. Remember your GBRs, okay? That's a requirement. It's not just optional, it is a requirement. You have to do it. It's just like how you have to sign 2 nurses to sign for taking over medication. The same thing with GBR.
Do
Doctor
you
have to
have
do it.
do you have Amazon Prime?
Okay? And if he's not going to reduce it,
I'll
that's where he
I'll send you
needs a
the money
psychiatrist to
on-
say
on
why
True
not.
Quick Pay. I send the money to
They can't just decide not to reduce to keep the patient on it all the time. You have to indicate why.
Just text me
the link.
can share it.
Yeah.
Now, one of the things you really want to look at, we've been talking about dementia just now, right? Vascular dementia, senile dementia. You have Alzheimer type dementia. Those are all type of dementias, right?
Mm-hmm.
But what is the word dementia? And before you get into that, let me just say this for this dementia. You do not give psychoactive medication, especially antipsychotic medication, to patients suffering with dementia. That is like driving down a one-way street against traffic, and the cop is standing right in the corner to give you a ticket that you will get, but you can also cause a bad accident. Do not give dementia patients unless that patient has dementia with behavioral agitation. If they don't have dementia with behavioral agitation, we don't put them on these medications. Because if you earlier when we started convenient medications, people will walk around. Some persons, when we, just to keep them safe, we put them on a locked unit, right? But the problem is, a lot of persons who are working on these locked units are being custodial nurses. They're not doing skilled nursing. They're just there to see that the patients don't do anything bad to themselves. We're not custodial. Nurses, we're psychiatric nurses. We understand human behavioral pattern. We understand how the medications can affect the patient. And the CNAs who work with these patients must also be trained. They're not just taken and put on the floor. How to interact with patients who have mental disorders. What's that, ma'am? Right now with the shortage, we've got nobody, just lock the door and keep the door locked. Because you don't have anybody to put up here. No, it's not just here. Right now throughout the industry, there is such a shortage of nurse. And we have LPNs in here. And I heard there are centers of hire. You know, centers is one of the largest nursing organization. Right now they're giving LPNs, they call them resource nurses. They send them from here to there in the center's facility. $80,000.
A year?
Sign me up.
I'm not working overtime, just normal shift.
Sign me
$80,000
up.
a year.
Sign me up.
Resource
Where do I sign up?
Centers, LPNs, they hire, of course, in these situations, it's that who knows who. So you don't have to go to state for the, like they're already going for the 10,000 or whatever, yeah, they're going to cut down, but it's going to come back. You hear what's happening right now with the COVID?
He's going back up.
They've gone up to what, yellow now? Gone back to yellow. You know the units is got green, yellow, red?
Yeah.
So now they've gone up to yellow, but I've not put anything in place to say don't do this or don't do that. But the moment it hits a little more upward, and I think it's going on. Because what's happening in China right now? They shut down, they lock down until now they get the problems with food, that kind of stuff.
It's like one person out of the house a week.
And they don't make joke over there. You guys is like the Americans talk about, oh, I'm not wearing masks, I'm not doing this. You don't wear a mask over there, you ain't coming out of your house. Period. They're actually letting people out only their house one time a week.
One person.
I'm telling you, and only one person coming out of the house.
To buy groceries.
Right now in Shanghai, which is how much millions of people in the city. So in America, you guys have thank you. God, you have that ability to do whatever you want to do here. Cost the government out, do all kind of stuff. But not in these places. But anyway, let's not stray away from the topic. Right here in America, things are getting worse. Again. Alright? And guys, stay with me please. And with each variant that comes up, each variant is more what? Contagious than the last. Alright? Let's hope that now they're talking about mankind is trying to live with it. Put things in place to live with it, not fight to eliminate it. Because it didn't look like it's going anywhere. It's like their HIV, where you got it, it's there. All viruses, where you got it, that's it. It's going away.
I'm gonna do that.
All right. So patients who have dementia should not be on these things unless it's to be dementia with behavioral agitation. And all the different type of dementias that we know we've been talking about. First, look up the word dementia, which you did before. You're going back.
Dementia is a
What is
loss.
dementia?
You want me to read it?
Go.
Oh, dementia is a loss of thinking, remembering, and reasoning skills.
Guys. Somebody's reading. Please give them that respect. Let's go, please.
Dementia is a loss of thinking, remembering, and reasoning skills. It is not a normal part of aging. Read about the different types of... Okay, that's it.
All right, just here. One of the things that people seem to think is that when you get old, you become demented. And that's crazy.
Let me know how much I can say.
What you have is opportunities, and if you have somebody in a family who have dementia, possibility. Right? But getting old don't mean that you're going to get dementia. So one of the things you said, the different type of dementias, and we mentioned vascular before, but now I want you to look at the old one. So let's look at the first one, senile dementia.
Senile dementia. Senile dementia is the mental loss of intellectual ability that is associated with old age. Senility is a decrease in cognitive ability.
You know, if you get older, say you're getting senile, right? Oh man, you're getting old, you're senile now. That means that you're losing the ability to reason, to make certain decisions. But senile dementia is a little more than that.
No, let me make sure.
And again, dementia don't come because of old age. It might increase the risk. Alright? So look at senile dementia again, so that when you are doing patient teaching, and people are talking certain things like, oh, she getting old, man, she got dementia. You gotta know how to address that with those persons.
Yeah, that's the right one.
Because in communities, especially in the West Indian community, we have a way of talking like that. All right? You're getting old, they're getting demented, don't worry them. It could be more than that. A person who is having change in mental status don't necessarily mean that they are having dementia. It could be related to changes in the brain, actual changes in the brain as related to some kind of disease process. Whether it be an infection, whether it be traumatic, whatever it is, can cause a person to have these changes. Remember the woman who had that tapeworm in her head?
It's 112.
Remember what I talked to you guys about last year?
11236.
When we read it? She had a tapeworm in her brain. And what was her signs and symptoms? She was forgetting even her own family members. She couldn't remember her family members. And when they did at NYU, when they checked, they said she had a tumor and did the operation, which it should not have done because the woman did not have a tumor.
There's not apartment.
She had a tapeworm. All that to give her is medication to kill the tapeworm. Didn't have to do brain surgery.
718.
But she said she didn't mind. I'm sure later on she was thinking about suing them.
718.
But she didn't mind that they did it to get the worm out because she said she couldn't remember anything. She couldn't remember family members, birthdays, whatever. Nothing.
362 or 360?
360.
So that's senile dementia. Now I want you to look at, and we did vascular dementia just already, so don't go, let's move on. Let's look at dementia Alzheimer's type.
Dementia, Alzheimer's type.
Called Alzheimer's type dementia.
It's coming tomorrow.
Thank you. It is a progressive, fatal, neurodegenerative condition characterized by deterioration in cognitive and memory, cognition and memory, progressive impairment in the ability to carry out activities of daily living, and a number of neuropsychiatric and behavioral symptoms.
All right. See the Alzheimer's type? Dementia is progressive, right? Alzheimer's
was
type, really worse. Yes, it's getting there, but it's progressive, degenerating. It's getting worse and worse and worse. To reach to the point that the person don't even know themselves. Remember when you do your cognition, or cognitive status, you say the person is alert and oriented times 3, right? Time, place, and person. Most persons may not know what time it is, especially if you're drunk, right? Most persons may not know where they're at. But when a person don't remember themselves, that's bad. And when a person with Alzheimer's type don't even know who they are, that's a problem. Now, because you look at the Alzheimer's type dementia, look at the word Alzheimer's. What is Alzheimer's?
Alzheimer's.
Guys, and please look at the sequence in which I'm going through these things, okay?
Bless you.
Anybody? What's Alzheimer's?
Oh,
Now it's very important. Diagnosing dementia, Alzheimer's. Look up diagnosing, how to diagnose, or how dementia is diagnosed.
How is
Not
dementia
sorry, Alzheimer's. How Alzheimer's is diagnosed.
How is Alzheimer's diagnosed?
May recommended one or more of these diagnosis tests and procedure as part of an evaluation.
There's a reason why I asked you to do that. Because of Alzheimer's, diagnosing Alzheimer's. Anything?
Diagnosed of Alzheimer's dementia, practice conduct tests to assess memory
sentence.
important thinking skills, large functional abilities, and identify behavior changes. We also perform a series of tests to
thank you.
the possible
Appreciate it.
Which is dementia. Remember we did just now dementia and Alzheimer's type dementia? Okay? So what I'm trying to get you to understand, please read up guys, is Alzheimer's and Alzheimer's type dementia. Are you guys with me? Please put those down because you're going to read about it. Now the next thing I'm going to ask you to read, and we're going to move now to something that is more psychotic. So we're going to go to schizophrenia. Look up schizophrenia.
Schizophrenia is.
Come on guys, shh, quiet please, just say focus. Schizophrenia. What is schizophrenia?
Schizophrenia refers to a condition and to a spectrum of disorders that all involves a disconnection from reality, including hallucination and delusion. It also affects a person's ability to recognize the symptoms they have of this condition. It's a severe condition, but it's treatable, and many people with it can still live happy, fulfilling lives.
Alright. A lot of persons who have this schizophrenia, as we said, they lose touch with reality, right? Hallucination, delusion, all this sort of stuff. But when a person has schizophrenia, if they're kept on their antipsychotic medications, it helps. But one of the things they say about these persons with schizophrenia, they don't recognize that they have a mental illness. So they don't want to follow any regimen. Okay? But if they were to follow the regimen, some of them work as doctors, nurses, judges. You will not believe it, people who have schizophrenia in places they have worked. Alright? Now, that's schizophrenia. Now, just now remember I said look at Alzheimer's and Alzheimer's type dementia later on. Now, I want you to look at schizophrenia and schizoaffective disorder. Schizoaffective. A-F-F-E-C-T-I-V-E. Schizoaffective disorder. If you read it, I read loud so everybody can hear.
Classified schizoaffective disorder has been considered as a very complete or presenting several diseases, some as hypotension and psychosis continuum. One of these contrasting views involves discriminating the psychosis of the classic symptoms.
Guys, what I need for you to do for me, alright, is, and this is for psychiatry, the words that I give you just now, I want you to do Alzheimer's and Alzheimer type dementia. I want you to do schizo and schizoaffective disorder, right? I want you to look at depression, versus, and all this is versus, right? Bipolar disorder, depression versus bipolar disorder. Schizophrenia versus schizoaffective disorder. Alzheimer's versus Alzheimer type dementia.
Depression and bipolar, right?
Depression versus bipolar disorder.
And schizophrenia.
And I need you to print that out for me, write that out for me. please,
Schizophrenia
For next
versus
week, Monday.
Versus
for next week, Monday.
Say again?
depression versus bipolar disorder.
Oh,
And what you said, you only have to bring them one day.
all right. Somebody repeat it, let me see.
He said,
Alzheimer's, dementia type 2, type,
he says Alzheimer versus Alzheimer type dementia. Mm-hmm.
And then he said depression versus bipolar disorder, schizophrenic versus what? I didn't get that one.
Schizoaffective disorder.
Affective disorder.
Schizoaffective
Yeah, affective
disorder.
disorder, I got that, yeah. Versus affective disorder.
I want you also to write a note in your own words on GDR. Short note on GDR. And a short note on TD.
Tardive dyskinesia. Tardive dyskinesia.
Tardive.
Tardive.
Dyskinesia.
What's GDR?
Gradual
Very short
reduction.
notes, but in your own words.
Gradual
Very short
dose
notes in
reduction.
your own words. Don't cut and paste or plagiarize. Alright? Don't cut and paste or plagiarize. I want to see that you have an understanding of what we discussed here today. Now, neuroses, before they used to put them into neurotic disorders and what have you, they don't use that any longer. Okay? Don't use neuroses and neurotic, everything coming under psychotics, right? Or mental health. And I can tell you that somewhere in your NCLEX, you will have it. You will have a question on one of these mental situations. They'll give you a scenario. Why? Because right now in the United States and even around the world, because of this COVID-19, a lot of people are having
Mental.
mental disorders. We have a lot of people who will be pushed off of this train station,
up, put in a
stabbed,
bag.
shot,
Shot.
and they're now relating a lot of these conditions to
The
the
vaccine.
COVID-19 is causing persons to have mental problems. People are forgetting. A lot of people are forgetting. People are having all the things that we talk about with hallucination and all that sort of stuff. People who have had COVID-19 having that. Now, the latest news for those guys is that it's not about dementia, COVID-19. They're talking about children, how many? 30 children, and one had died, who now having liver disease.
Yeah, there's just something going on.
Guys, keep your head to the news, because usually these are the things that's happening, is what comes up in tests. Because it's nurses is write these things. So it's what is current, they will put together and put into thing. Should children die from liver problem? No. And you as a nurse are knowing when you have liver problems, how will it manifest itself? How will it manifest itself?
Affect the kidney.
Look at the yellowing of the eyes and the skin, the bilirubemia, the jaundice. That's the liver. So if you see the child eyes are yellow, I don't have to be yellow, it could be just slightly yellow, or the skin got a yellow hue. This is something that they don't know right now. They don't know if it's a virus that's causing it. And anything that they don't know, and it's a good thing now they're saying that they don't know. But what's bad about it, one child died of it. Viruses is playing a havoc, and soon we're going to be living in bubbles. I kid you not. You're gonna not want people to come to your house if this keep up. They're gonna be like what's happening in China now. You don't want people to come to your house. You don't want to be associated with certain situations because these diseases have become. Remember, you guys have heard about the bubonic plague? The bubonic plague that happened a while back, many years ago, where people were just walking and dying in the streets. Let's hope we never reach this back again. In Africa, when you had the Ebola, people were walking and dying in the streets. You know why we don't really seem to worry about it? Because it's not happening here. You know what people got worried about the COVID-19? When they start hearing about bodies being in trucks, parked up on the road and all kind of stuff. Then people start, and even that people didn't even start worrying about it because it did not touch them. But if you work in facilities like I did, and I've seen every day 2-3 people coming down in body bags, and they start smelling because of the refrigeration unit was now, where we store the bodies was not properly refrigerated. You're going to understand what it is like. That's why I'm very particular when it comes to infection control. Very. Don't mess with it. There's so many microorganisms out there that is not responding to the antibiotics. All the antibiotics that we're using today have been around for over 30 years. Everyone antibiotics. We have nothing new to really kill anything. These new resistant bacteria, we have nothing to kill the bacteria, to kill the viruses. And now the bacteria that we have, the antibiotics used to kill them, now they become what? Resistant. So if you have these bacteria that used to be killed by antibiotics, no longer dying from these antibiotics. So why would you want to get it? Protect yourself. That's all I say. Protect yourself. Wash your hands. Careful how you associate with it and what you touch and what you move around with. One of the things I do every day, I got a little bucket by my receiver. And inside of it, every day I put hot water, bleach, and everything that that's gonna go into me, gotta go into that bucket. A pail. And soap. Every spoon, every fork, everything, plate, gotta go inside there. Very good. It's making you become paranoid. And that brings me to another one. Look up for the word paranoid schizophrenia. Look up for
Paranoid schizophrenia.
Somebody read, please. Guys, this is not funny. These are schizophrenias. They're different types. And if you don't know it, the different types, and you see drugs come up for it or what have you, you may not answer it right. What is paranoid schizophrenia?
Paranoid schizophrenia characterized by really positive symptoms of schizophrenia, including delusion and hallucination. These debilitating symptoms blur the line between what is real and what isn't, making it difficult for a person to live a practical life.
Okay. So, apart from the three verses that I gave you before, put paranoid and paranoid schizophrenia. Put paranoia, and paranoid versus paranoid schizophrenia.
One more time, please.
Paranoia or paranoid versus paranoid schizophrenia. And you must be able to come and be ready to discuss these things in your own words. And if I have the class I don't see on Monday, I know why.
So it's me one appointment, so nobody.
Let me tell you guys, whenever I say that something is expected, that day that I say expect something, half the class don't be here. And then when I come and I said, people didn't handle things, oh yeah, go get. You're going to see all your papers, people. You're going to see all your papers. Got nice to find on everybody. All your papers.
Paranoid schizophrenic versus paranoid.
Paranoid versus paranoid schizophrenia. Paranoid versus paranoid schizophrenia.
Paranoid schizophrenic versus paranoid, right?
Paranoid, right.
Yeah.
Not paranoid schizophrenia versus paranoid. That's what you read just now. Paranoid
Schizophrenic versus paranoid.
Paranoia.
Paranoid.
Oh, you said paranoid.
Now, when we know about a person who is paranoid, what's about a person being paranoid? What really would tell you that this person is paranoid? Don't read up nothing. Just come. You hear about it. Person, man, you're paranoid. You crazy. Get out of here.
Something I
What's
get
it?
scared right away.
No, that's not why.
There's somebody that everything, like everything you gotta be meticulous to them.
Unless they feel like something is gonna happen to them and they.
Unhealthy suspicions. They suspect everybody is talking about doing something. A person, and this is a question that can come, because it has come in other scenarios. A person with paranoid schizophrenia or suffering from paranoia and is paranoid does not want to eat the meals that is brought for them. What will be your intervention as the charge nurse of the unit? to ensure that this person have adequate nutrition. Man, cook food, I don't want that. Y'all trying to poison me. So what will you do? What will one of the things you try to
Okay, would you
implement?
like to go and get your meal and bring it to you?
You trying to poison me, I know you.
I'll show them the meal in the original packaging, so they don't think that it was tampered with. And I open it in front of them.
Ensure that it is not open. So when it comes to them, they open it themselves, or you open it in front of them.
Yep.
Very simple. Because they're paranoid, they're suspicious. Like we know in the Caribbean, we hear that when certain women want to keep a man, they cook food and they do something with that food. They call it steam out. So if you steam out, the man will never leave you.
Why you do that?
Nasty stuff. Very nasty stuff.
It goes both ways.
They got the pot here,
The men do it too,
and then they
right?
go sit down over the pot for the steam come down. So the man will never go leave. What? People do all kind of stuff. Remember, belief kills and belief cures. So that person